I think actually I should have probably done some disclosure. So that, like as he was talking about, we got a developmental pediatrician. So that's really a jack of all trades and master of none. So I really am not sleep trained like Dr. Heubi is, but a lot of the sleep concepts are good to think about no matter for anyone. So what I think is really kind of tricky is there's not a whole lot known on kids with charge and sleep. And so Dr. Hartshorn here has got 50% of the literature based on my query. So we should have invited him to give this talk rather than me. But we know most about behavioral sleep issues in the general population. And then there's some information about sleep within specific syndromes or kids with vision impairment, kids with, and so forth. So that kind of is the best we can pull together to try to sort some ideas out. So if we look at what we know about kids with charge, Dr. Hartshorn's group has done 2 nice surveys and pretty large surveys. One was on 53 folks with charge who were 13 and over. And this was some rating scales where they saw 25% of kids with sleep apnea, and Dr. Heubi's going to talk more about what sleep apnea means and that sort of thing. But 60% with sleep difficulties, and when they looked at who had sleep problems and linked that with behavior in the daytime, anxiety, self-injury, conduct and autistic features were kind of linked and correlated. So correlated means they're associated. We don't know which direction that relationship goes, but it's an important thing. When we know in the general population, kids who have poor sleep often have more troubles with behavior during the day. We were talking in the back about during residency, being sleep deprived, how our problem solving and our driving were probably not safe. And so that it's good that people have recognized that and have changed the hours that residents are required to be on site from time to time. So again, the second study Dr. Hartshorn has done looked through the Charge Foundation and surveys, and this was a really exceptional survey rate. So he had almost 90 folks return their surveys, and they did some specific behavioral checklists and sleep scales. And again, found a very high rate of sleep problems. And when we think about the behavioral piece, starting and staying asleep were big problems. Then sleep disordered breathing, which is more that snoring, and sleep apnea, and then those transition points between sleep and wake. And I thought it was interesting too because the kids who had more sleep problems were often more those with more substantial vision and hearing issues, and that makes some intuitive sense to me. And again, kind of similarly, this larger group, what went along with having troubles with sleep? Well, being self-absorbed, disruptive, and some anxiety and social difficulties. So if we're not sleeping well, we tend to think about ourselves. No, I'm like thinking about myself. Get a little more irritable and so forth, and anxious. So I think too, sometimes people wonder like how much sleep does anybody need? I feel like I get that question a lot, and it kind of depends because it's really based on ages. And again, this is more in typically developing children. So babies sleep a lot, anywhere from 12 to 19 hours. And babies, they're up and down, and so they're not really consolidating their sleep. They're very, at nighttime they're up more frequently. But as kids get a little older, they need less sleep, and they start consolidating a little bit better at nighttime and making those naps a little bit longer and spread out. So that's how we hope to see kids sleep. And then I think, it's easy to kind of think, well, I'm going to get there, but it's really easy to forget how important just what we call sleep hygiene is. It's not how clean you are at nighttime, but how do we promote good health habits? So those schedules and keeping that routine. Being active but not too close to bedtime is good. If I run too late, then I'm up too late. Avoiding things like caffeine. We're not promoting smoking in your kids, but these are, or alcohol. But those are things that also, for us as individuals, can interfere with sleep. And even napping, and kind of when do kids nap? Is it too far into the day, and is that kind of going to push our bedtime routine back a little bit? And there's a number of things that you can kind of do to make that transition from activity to settling down better. Relaxation, a hot bath, that sort of thing. And just even what's in the space where we're trying to sleep. I think a lot of times if you go on MSN or whatever and find out how do you sleep better at night and not stay awake. Well, we probably shouldn't be reading our Kindles till the middle of the night, and that electronics is really kind of disrupts even our sleep-wake cycles from that light exposure. Because really, the way our world goes, except for like in Alaska, is we respond to that light of the sun in the dark, and so kind of thinking about, is it cool? Is it not too noisy? Is it relaxing? Is my bed full of laundry, or can I just get right into it? So I think too, timing for sleep is tricky, because if we try too soon, and a kid's not sleepy, you're gonna really kind of, it's not gonna really be productive. So if your child needs less sleep and you're trying to get them to go to bed at 7 because you need to go to bed early, but they're not sleepy till midnight or 10, it's gonna really not promote necessarily falling asleep. We talked a little bit about that environment, lighting and temperature, and even where kids fall asleep. So sometimes it's easy to have a kid fall asleep wherever they are. I've had kids who just run around and then they just fall. That's how they fall asleep, right? They're in nonstop until they fall, and then wherever they fall asleep, we then move them to, okay, we want you in bed, we're gonna put you in bed. But then when they wake back up, it's like, where am I? I didn't remember I was here. It can kind of make a kid harder for that child to kind of settle back down and fall asleep. I think too, even when we think about bedtime routines, I know this is really basic stuff, but those routines are really helpful for all kids and adults, like keeping that routine, keeping that regular schedule, but not making it too long. So sometimes kids will want to prolong, and but now I got to have 5 books, and I got to go check, kiss 20 little stuffed animals, but keeping that kind of short, having it calm down rather than activate. I love dads, but I think sometimes not, so I think about some dads who let's rev you up and wrestle right before bedtime. Well, maybe that's gonna work, but usually not, because it's gonna ramp you up. So what can we do to kind of settle you back down? So wrestling is fine, but maybe not right at bedtime. Sleep associations are also really a thing that happens a lot. So when we fall asleep, when you fall asleep, what is it that you take to fall asleep? I mean, I do like to read, and then I kind of fall asleep. And to me, that's my sleep association. That's kind of a thing that kind of helps settle my mind down. But we have to think about this a lot. What is it that helps a child fall asleep, and how we're helping that or hindering that? Now, we're going to talk about charge next, so don't worry, because I know that what I'm saying isn't exactly easy to do, but are we needing to rock you to fall asleep, or do you need your bottle to fall asleep, or do you need a passy, or what is it that's helping you kind of settle down and fall asleep? So what happens is we sleep, and then through the night we kind of wake up a little bit, and whenever we kind of arouse a little bit, we kind of need whatever it took to fall back asleep sometimes. So if a child gets used to a certain way to fall asleep, and they wake up, they're going to need that often going to need that to fall back asleep. So these sleep associations are really kind of helpful when you walk through and think about why a child is having problems waking up through the night. Thinking about what happened at the time of going to bed is really gives us some insight into what might be happening in the middle of the night. So I'm going to make this a little more interactive. So I know I said all those things, and you're just like, throw them all out the door, right? What is it about kids with charge that are different than these things? This is for every kid, every person. Routine and those things are going to help. But of course, there's reasons this doesn't work very well for charge. So give me some of the things that make it hard for your child to fall asleep. Yeah?
Respiratory treatments every 4 hours.
Respiratory treatments every 4 hours. Absolutely, yeah. Medications they have to take to maintain something. Yes?
She's had a really active day or a zero activity day. She has a lot of problems, even on routine, falling asleep.
So days that are either unusually high activity or unusually low activity, even if it's a reasonable routine, makes it hard to fall asleep at nighttime. Did I capture that right? Yes? Yeah, you can't close your eyes all the way. Now what do you do about that? Yeah.
Snoring and coughing.
Snoring and coughing. Mm-hmm. Yeah. Pain is a really good one, yeah. I mean, not a good one, a good answer. Yeah, somebody over here was. I'm surprised nobody said nursing support yet. Go ahead. Reflux. Okay, yeah.
Nursing support, because we have nurses that need to have the lights on so that they don't fall asleep.
The nurses have to have the lights on so they don't fall asleep. Ugh. So we're hopeless, aren't we? All right, any other? These are all great ones. Yeah. Anxiety. And can you expand on that a little bit more? So he can't turn his mind off. What are we going to do tomorrow? And thinking that through just makes it hard to settle down. And so, yeah. Feeding pumps, BiPAP, what?
They make noises when they're not happy.
They do make noises when they're not happy. And unless that's a sleep association, it's just not going to work, is it? All right. So I don't have any good answers. You've hit most of my concerns. Although people, yeah, so the alarms, nighttime nursing, medical issues. Vision, depending on the degree of vision issues, it really can affect melatonin production too. So that's another aspect of charge that we need to at least think about. So the light and dark cycles affect how much melatonin you make, how much you're seeing that and processing that. And so that can be an issue. And then I think too, hearing loss, sometimes when you think about if I'm relying on my hearing and I have to turn it off, I've lost some of my bearings and my awareness. So what do we have to do to think about that? And am I comfortable not being able to hear at that time? So what strategies have you guys used? I mean, I think I came up with some, but honestly, so with those medical issues, what are some strategies? So I think people talk about needing medicines at certain times. Have you talked to docs about, does it actually have to, I mean, sometimes things do really have to be regimented, but sometimes maybe we're more flexible with 3 times a day versus every 8 hours. I don't know. What have people come up with to help fix those problems? You're just like, no, nothing. Okay. Yeah.
We've turned down the beeps on a lot of this equipment.
Like gotten the alarms quieter or turned or
Some of them you can silence.
so silencing alarms. And if your nurse is there to, so how does the nurse know when the alarm? They just have to keep. She has to be alert. Okay. Yeah. No. Right. Which means she needs the lights on. Just kidding. But from a sound perspective, that's good. What else have people tried? Yeah.
This is not probably the best thing, but I think Mackenzie does not like being in the dark.
Uh-huh.
So we do let her sleep with the TV on.
Yeah.
If the TV's on, she'll stay in her room and not turn all the lights in the house on.
Right.
at night.
So she said her daughter likes to have some level of light, and by letting her keep the TV on, even though that's not the perfect sleep hygiene, it allows her to stay in bed and not turn all the lights in the house on. And honestly, if that's the only thing that she needs, hey, stick with it, right? I mean, I think other strategies.
We do observing touch time, so like trying to only touch him during those moments where we have to do the respiratory meds instead of trying to change a diaper, like in the middle of between respiratory meds. So trying to schedule everything so it's done
Right.
at specific times and we do as much as we can.
So they try to consolidate care in a way that there's less disruption and physical bothering at one time. And so like diaper changes and stuff like that. I mean, yeah, it's pretty tricky. And then I guess the other thing I realize is as soon as you have an inpatient hospitalization, everything's all back to bad again, right? Yeah. Because we're not very good in the hospital at these sorts of behavioral things at all. Yeah, I think we did, can your providers and hospital providers too respect a nighttime routine? Can you get that on your care plan? Can you get your nurses on board with, kind of some consistency? I think the night light piece is not a bad one. I think that can be helpful. And we talked about melatonin already. I've had some families who've said their kid doesn't want to take their hearing aid or cochlear implant off, and they just wait till they're asleep to take it off. And I mean, I know that's not great for, you got to get the dehumidifier and all that good stuff, but That's still something to think about. And then, I mean, I guess I always come back to your nurses about how do we get your nursing staff or care staff to consolidate and think. And this is true for behaviors too, right? I mean, how many different people touch your child and what they're focusing on, what we're doing. I don't know if these are that relevant or not. I mean, I guess I was curious too, because if a kid's having a hard time falling asleep or it's taking a long time, I feel like there might, how do we help kids self-soothe? So as much as I need to learn this, how do you, what I feel like is sometimes kids with charge really have a hard time figuring out what it takes, or there's a certain way they self-soothe that we might not be letting them do. So what are some of those, I mean, does anybody have any guidance for other people around soothing or calming strategies that they've used for their kid that seems to help? Yeah?
These are not my strategies, but he's developed his own.
Mm-hmm.
He will sit up, he does his W-sit, not ideal, but he rocks, and I think he gets this input.
Yeah.
I mean, he has all these stuffed animals around him, and he's hitting his head rhythmically on all those stuffed animals. And then even last night, he doesn't have a weighted blanket, but he has enough stuffed animals to be weighted, and I think that gives him a sense of calming.
So let me tell, because they can't all hear you. So and then we'll come back. So one thing her son does is W-sit and then does a rock and hit onto stuffed animals. Rocking, head hitting, I know that seems really distressing and bothersome. This is actually something typical kids do too sometimes. They'll hit their head to fall asleep, or they'll go back and forth. And unless they're causing major injury, it's actually not a problem. There's a good 25% of college students will rock in a rocking chair. It's this repetitive movement thing, and it's a soothing thing. So as long as it's not causing harm. So that was one, sorry. And then
The other is the deep pressure. Once
Deep
he
pressure.
goes to sleep when he's ready, he likes blankets on him and a pile of stuffed animals on top of him, and then that seems to help keep him asleep.
yeah, so deep pressure, and then those animals on top of him kind of keeps him asleep. I think we've had folks who've tried weighted blankets. I think our institution has kind of backed off from those a little bit because there was a problem with somebody had too much weight. But that heaviness, some people like that. Some people like nothing on. So like, what is it that helps you stay asleep? Other things that, yeah. So doing some circle walking until I can settle down to fall asleep. There's nothing wrong with that, right? I mean, there is nothing wrong with that. So if that's what soothes you and gets you there, go for it. Other strategies? Yeah.
My son puts his stuffed animals to bed and follows the exact routine, whatever he does with his animals that he then has to do.
Yeah, so follow a stuffed routine. So he puts his stuffed animals to bed at a certain routine, and then he follows that routine. And that routine really is, as long as it doesn't get too long, is a great way to kind of keep things moving along. Those nighttime worries, I think it kind of depends. So sometimes it's a nighttime worry around it's dark, there's monsters, or I'm thinking about tomorrow. So depending on a kid's communication level, what can we do for that? I mean, littler kids or lower communication, monster spray if you're worried about something underneath the bed. But also social stories. So I think particularly, and even some of the mindfulness stuff we did today is, as I'm thinking through, do we want to draw a picture to put my worries down and then I can leave them there on the book and then we can go back to sleep? And how do you get rid of those worries? Social stories are something basically, I don't know why I keep holding this up, I think it's the mic. Is like you build a story around something you want to have happen. So at nighttime, I sometimes still have a lot of energy, and I'm going to get my energy out by walking around, but then I'm going to settle down and da-da-da or whatever. Or sometimes at night I think about tomorrow, but I'm going to write down my ideas, or I'm going to do some pictures, and then I can think about it tomorrow. Those sorts of things might sometimes help. I think sleep associations are tricky to kind of fix post facto, but trying to think about that ahead of time is how can we help kids fall asleep and build their own ways to sleep. Again, everything's going to be messed up once you get back to the hospital. When kids wake up through the night, sometimes it's a medical thing, sometimes it's the fact that sleep association issue. Nightmares and night terrors are something that are kind of common too in kids. Nightmares really are that kind of dream. It's a bad dream I remember, and I can talk through night terrors, kids will wake up and look distressed as all get out, scream, and their heart rate's beating, and you can't calm them down, and nothing you do can calm them down. And they don't have any memory of it the next night or the next morning. So kind of figuring out what's going on if kids wake up very bothered and upset, to kind of sort that through. If it's a night terror, well, I should probably leave that to the sleep medicine doctor, but sometimes what we can do, especially if it's the same time every night, is we can try to disrupt that cycle, because it has to do with the sleep cycles and how they're kind of moving through them. Is that fair enough? Yeah. Close enough? Okay. I mean, like not perfect, but, and then nightmares, I think things like talking through, reassurance, dream catchers, whatever, and this will catch your dreams so you don't have to think about it. And how, what else you can kind of think about for dreams. I think the other thing was interesting that I put lavender in here for just other things. And then Dr. Cotton kind of brought lavender up. I mean, a lot of folks do look at aromatherapy and other kind of ways to help kind of make that sleep association or that calming down. I'll probably leave melatonin questions to Dr. Heubi, but there's two ways to do melatonin. One is like a high dose at bedtime, and that kind of sedates you. But there's another way to use melatonin where you do a smaller dose at dinner time, so about dinner time, and that kind of boosts your own melatonin production to kind of get you asleep better. So if you hear that as a way to use melatonin, it's actually sometimes a really good one. And we've got some folks with some experience on that that's actually helped. And Dr. Heubi's also going to talk a little bit about the role of light and light boxes and kind of what we can do for that. But I want to make sure she has time to talk as well. I said that sometimes we do have to go to medication. That's not necessarily what we want to, but when we realize when kids have really disrupted sleep cycles and it's really affecting the daytime stuff, sometimes we just need something to kind of get us back on path. Sometimes that's something you need to do for a while, and sometimes it's just a 2 to 3 week restart of your cycles. Yeah.
Since you brought up lavender, what if they don't have an olfactory?
I know. It's really, yeah, I know. Yeah, I don't know. Exactly. No, it's just tricky because there's so little known about what works for sleep and charge. And I don't know if your group felt like you found some strategies or ideas, or maybe we'll hear about that tomorrow.
What you've mentioned.
Okay. Well, good. Phew. Alrighty. So what I mentioned is really just the general tenets of good sleep. And in fact, when you look at other syndromes, that's often rare syndromes as well, like Angelman syndrome, those kids have a lot of problems with sleep. Sleep routines really do make a big difference. But I'm excited to have Dr. Heubi give you more medical knowledge and not just the behavioral piece.
So I'm Chrissy Heubi. I'm one of the pediatric ENTs, and I'm board certified in sleep. And I feel really fortunate to work with Dr. Wiley and try to work together on the behavioral and sort of the basic sleep principles. For just to touch on night terrors, so we typically do not recommend you wake your child up during a night terror, just in case anyone is familiar with that. It's very scary, and your first instinct is to comfort your child, but they are still asleep, so you actually just want to let it ride out. Occasionally we do, if they have them repeatedly, like it happens 3 or 4 times a week, it's the same time every night, you can do a scheduled wakening like 30 minutes before the time. We don't do it a lot, but for sure if it's very disruptive, that is a strategy that we do try. Okay, so I'm going to talk about sleep, and I think everyone here is a parent, and they know that if your child's not sleeping, you're probably not sleeping, and if there's other kids in the house, it's incredibly disruptive. I'm going to do some focus topics in sleep, look at visual impairment in sleep, circadian rhythm disorders, sleep disordered breathing, and then just some other concerns. And I think we'll have time to end for questions, because a lot of this is general knowledge, but we've tried to tailor it towards children with Charge syndrome. So what is the impact of a visual impairment on sleep? So this, for everyone in the room that's uncomfortable with science, this can be a challenging slide, but there's a picture here, and there's 2 processes that drive our sleep. This is for everyone. The first is our homeostatic, what I call the drive for sleep. And this is, I like to think of this as a pot. If you're boiling water, you put a pot of water on the stove and you start boiling, it's very calm, and then it starts bubbling to the point where it bubbles over. And that's a little bit like how we are naturally during the day, right? So we start very calm in the morning, most of us, and we sort of work up into the night, and then we're so tired, the pot is bubbling over that we need to sleep to get back to baseline. So that's a natural drive we all have to sleep. The circadian rhythm is your clock. So most of us operate on about a 24-hour clock. This is primarily modulated by light. So light exposure in the morning gets us started, starts our clock, we're alert. As the day goes on, our melatonin actually gets released, and if you're exposed to light, it will suppress that melatonin release. So in general, the melatonin kind of puts you to sleep. So those are the two pieces that drive your circadian clock. So historically, we have thought that people with visual impairments, and certainly blind individuals, they have more sleep disturbances because they don't get that light exposure. They don't get entrained. Their clock is not entrained by light. And because of that, they have abnormal melatonin release. What ends up happening for many of those people is that they have a free running circadian rhythm, which I'm going to show you a picture of that. But what is relatively new and kind of exciting, and we've kind of in the sleep world kind of known about this for a while, but now there's a little bit of data on it. There's newer evidence that some patients who are blind or have visual impairments actually retain the cells for photic circadian entrainment. So this is kind of a big deal, because we always thought if you can't see, then you probably can't get your triggers from light, and your melatonin is sort of out of whack. But a recent study of 16 blind individuals where they exposed them to bright light and then they measured their melatonin to see if it was suppressed by the light, half of them were responsive to light. So this is pretty important for us, because I do have families that come in and they say, well, my child can't see, so I'm not going to follow your sleep hygiene instructions, and I totally understand that. But now I think it's important to actually uphold those and try them in your child. The recommendations are, and again, for someone that needs the lights on for nursing or other reasons, I understand if that's not feasible, but our recommendations are blackout shades in the bedroom to have a clear delineation between night and day, early morning light exposure for about 30 minutes. Natural light is great if it's possible. I'm a big fan of breakfast rooms or dining rooms that have light. Some people keep their house very dark, but you really need that light in the morning. If you live in Alaska or somewhere where there's not much light, we can use light boxes. And then this is a tricky topic now because everyone has a device. So we recommend no device usage for an hour before bedtime. And it's hard for me to recommend that to families that have children that their main way of interacting with the world is a device, or the way they communicate is a device. And I always get the question, well, we have the blue light filter, so we can still use the device, right? And the reality is we don't have any data on whether using the blue light filter is actually effective. So for now, if your child is having sleep problems, particularly sleep onset issues, I think it's worth at least a trial, if possible, to discontinue the devices. And keeping with that, I used to tell people to keep their TV out of the bedroom, and now everyone says yes to that, and then I find out that they have an iPad and iPhone, and it's checked multiple times during the night. So you can do yourself a favor and your child if you can turn them off and put them aside before bedtime. So what happens if you do have a free-reigning circadian rhythm? So if you look at this chart on the right here, this is a plot. The time of day is not really that important, but what you see is the solid line is sleep. And this circle is a relatively normal sleep cycle. So you've got the sleep time is in the solid, and then the dots are the daytime. Most of us probably run about like this. We go to bed about the same time, 1 to 2 hours difference potentially on the weekend, and we are awake at similar times. If you don't have these cues from melatonin and light and you run on a free-running circadian rhythm, what happens is your sleep drive drives your sleep cycle. So you go to bed sort of later and later every night, and it's really just that drive for sleep gets you, and you just have to crash. We see this in kids, obviously, that are visually impaired, but we also see it in kids that have spent a lot of time in the ICU or the hospital. It's the worst place to get sleep for anybody, but they don't respect you can't respect like night and day. It's artificial light. You're sort of always on, and that can be, the result can be a free-rating circadian rhythm. We've also found some kids with charts have come to our clinic, one in particular that we treated with light box and melatonin to try to get on a sleep cycle, and it ended up being that he had underlying autonomic dysfunction, which is very difficult to diagnose and very difficult to treat, but it's something to think about if someone's working with you and trying to use melatonin or a light box to try to get on a schedule, there may be something else going on. The last thing that is kind of common in all kids that I wanted to touch on is a delayed sleep phase disorder. So some people's school districts now, the high school starts later, and that's based on data that kids, as they enter adolescence and become a teenager, they have a natural propensity to go to bed later and wake up later. This can be really difficult because they found that accidents were more common on the teenagers driving to school, so they moved the start times to later. Not everyone has done that. Sports is a huge driver in a lot of schools, and so they keep the times the same because they have to do sports after school. So some adolescents are not affected by this at all. You set an alarm, you get them up, and they're fine. And then they sleep in on the weekends, and they're still fine the rest of the week. A lot of kids are affected by this. We do use melatonin and light therapy to treat this. And some kids really struggle, and I think it's important to keep this in mind because your child might be one that if they get a job after high school or they're going off to college or some sort of post-high school schooling, they can pick their school start times later. So I recommend that these kids think about not taking an 8 a.m. class, afternoon classes, because that's typically when they do better. So it's just something to keep in mind. That's probably the most common circadian rhythm disorder I see in children, outside of these free-running circadian disorders. So how you kind of figure this out, the best way is to keep a sleep log. And I recommend you do 2 weeks because there's often variability in a week. This is actually from the American Academy of Sleep Medicine. It's a 2-week sleep diary. And you see on the side, you get to put the date. And then you want to put what the child is doing. Are you on vacation? Is it during the school week? And then you basically, the boxes, you darken this when the child's asleep, and you want to put their nap times also. If you come to see a sleep specialist, they will be elated if you show up with a sleep diary, because this is so incredibly helpful for us to figure out how your child's sleep is and how we can help you. So I'm going to switch gears a little bit and talk about something that's pretty common in all children, and then I'm going to talk a little bit about what we know about children with charge and obstructive sleep apnea and sleep disorder breathing. So obstructive sleep apnea, or OSA, is seen in about 1 to 3% of the population. What it is, sort of made simply, is when your airway closes off during sleep. So it's partial or complete obstruction during sleep. What happens when you close off your airway is you may desaturate and become hypoxic, or you can actually hold on to CO2. You're not blowing it off enough, so you hyperventilate and become hypercarbic. The risk factors for sleep apnea in kids are enlarged tonsils and adenoids, obesity, craniofacial anomalies, and neuromuscular disorders. So this is what we commonly, honestly, for anyone who doesn't like medical pictures, but for us, this is great because I can usually fix this. So if a child has big tonsils and adenoids, you can imagine that when they relax, this closes off the airway. And that results in disrupted sleep snoring and often obstructive sleep apnea. So why do we worry about this? Well, it is incredibly disruptive for your sleep. And when you're not sleeping, it's going to exacerbate daytime problems or create behavioral problems during the day because your child's exhausted. It also can lead to some pretty significant health consequences: cardiovascular disease, high blood pressure, pulmonary hypertension, and it's associated with a higher rate of diabetes and abnormal glucose metabolism. So now we'll get back to why it's relevant for everyone in the audience. So there isn't very much, like Dr. Wiley said, in the literature, but there are 3 studies I'm going to point out to you. So this is a case report that was published in 2012. It was a 1-year-old with charge who had frequent nighttime awakenings and really did not sleep any longer than 3 hours. They had snoring, stopped breathing during sleep, and they were mouth breathing by day. They had daytime somnolence, just sleepiness throughout the day, and some behavioral concerns. So a sleep study was performed at 18 months of age and showed obstructive sleep apnea. They trialed continuous positive airway pressure, Cpap, which you may know about and I'm going to talk a little bit about in a few slides, but they didn't tolerate that. At the time, a tracheostomy tube placement was discussed, but they ended up doing an adenotonsillectomy, taking out those adenoids and tonsils, and I just showed you that picture of the tonsils. They got complete resolution of their symptoms except some of the behavioral concerns. So this was kind of a case report highlighting how patients can present. This is work by Dr. Blake's group. There were 2 studies. One was on adolescent and adult issues in charge syndrome. And what they did was they did a 45-minute interview of parents and or individuals with charge. There were 30 patients that were interviewed. And this was on a variety of issues, but what they reported was 43% had sleep apnea. The second study was actually using a variety of our sleep questionnaires to ask families to sort of screen for sleep apnea. They were trying to figure out if in this population we can use these questionnaires for diagnosing or at least screening for sleep apnea. It was entitled Understanding OSA in Children with Charge Syndrome. Parents of 51 children filled out the questionnaire, And again, they were using questionnaires, but one of the history questions was, do they have a previous diagnosis of OSA? And in this group, 65% had OSA. So I think this highlights that there is likely a high rate that we just don't know and we haven't really explored yet. So, when I talk to groups about like children that have special medical needs, and I'm always asked like, well, why don't we know more about this? Why is there not a lot of research on this? Well, I think we have to keep in mind that sleep medicine is a relatively new field, particularly in pediatrics. They actually didn't have scoring for pediatric sleep studies until a few years ago. For many children with charge, if you have a tracheostomy tube in place, this really isn't a concern, so it's not even on the radar. Many parents, their child has had disrupted sleep their entire life, so this is something you think is just normal, and say this is just how my child sleeps. And the last thing is I think many children, you have life-threatening medical problems that you're dealing with, so sleep apnea is a little bit further down the road. But it's important to highlight because the health consequences of sleep apnea, we need to be screening for it to sort of give your child the best advantages and have the best overall health. But again, the behavioral problems, failure to thrive, cardiac problems that you can see in your children are also associated with OSA, so it's hard to ferret out which one is the cause. So screening for OSA in a perfect world, your pediatrician or your ENT, local ENT would be asking about these symptoms, but it's not always the case, and these are things you just need to keep in mind. If your child is snoring, if they stop breathing at night, snorting or gasping, choking, sometimes the only noise people hear is a big gasp, and it's because their child has stopped breathing and then their brain tells them to breathe and they take a big gasp like that. So that's a symptom of obstructive sleep apnea. Unusual sleep positions, if your child hangs their head off the end of the bed or they can only sleep on 2 or 3 pillows, that's something I would want to talk about more. Restless sleep and then daytime somnolence. And this can be kind of tricky, but the best example I have is sort of the 3-year-old that every day on the bus sleeps for the hour bus ride home. So that's not typical of a 3rd grader. That's not typical of a 3rd grader. And then if the child is falling asleep easily or when the TV's on, that's also not typical. So diagnosis of sleep apneas with a sleep study. This is probably the only time I tell families, I'm usually pretty good about like go local, like see your local doctors. We support like you not having to drive a lot of long distance to get something done for your child. But for a sleep study, you really need to do it in a pediatric sleep lab. The adult sleep labs, they don't measure CO2, so that's an issue because you need to know how much CO2 your child is retaining. And they use different scoring. And in some places, they do a great job and they're able to differentiate between the two, but not always. At Cincinnati Children's, we actually have a second respiratory therapist that comes that day with your child if you have special needs to help with hookup. And that can make a huge difference because one person can get very frustrated. So if you have 2 there, it's helpful to sort of navigate. When you're looking at a sleep study, there's 2 components. There's apneas, where you completely close your airway, and then there's hypopneas, where you partially close your airway. And what we do is we average the amount of those over every hour of the sleep study to get what's called the Obstructive Index. Again, this is important because if you have a provider that's not really clear on the differences between pediatric and adult sleep apnea, they may say that, say your child has an obstructive index of 10. So if you look at the pediatric scoring, that's severe sleep apnea. If it's an adult provider or someone that's not familiar, they're going to tell you of mild sleep apnea, and they may say, let's just observe it. And that's really, we should be doing better for your child. So in addition, for patients who have charge, you need to be looking also about the level of oxygen throughout the study. So non-apneic hypoxemia is when the oxygen level is less than 92%, not associated with these events. And I think it's more common in children with charge due to their coexisting cardiac disease. Lastly, I look at a lot of sleep studies, and if I see a child that continuously desaturates into the 60s and 70s, I'm worried about their lung status. And the first thing I look at is the child aspirating? So that's like another clue if you get a sleep study and the SATs are really low. Either your child needs to be evaluated for aspiration, or that's what they're currently doing. Now, it's not always true, but it's definitely a tip-off for me to take special caution on that. So we can treat obstructive sleep apnea a lot of ways. The American Academy of Pediatrics guideline is to take out the tonsils and adenoids as the first-line treatment in kids that have enlarged tonsils and adenoids, and it's very effective. For kids with mild OSA that really don't have big tonsils and adenoids, we'll manage them medically with Flonase and Singular. And then Cpap is kind of a hot topic because we've actually had more success in children. There's not much data in terms of the compliance, but overall it's about 50% compliance, but it works. I mean, in the majority of kids, if you can get them to wear it, it can be 100% effective. We've also come a long way. This is what we call a Giraffe Mask, and it's been made specifically for kids. So it's a nasal mask, looks like a giraffe. I think actually they come with a giraffe. They show you the giraffe. But my experience with this is that, in adults, it's like you have to buy into it as an adult. Are you going to wear this? Like, you're not. If you show up at the office and they say you need to wear this and you're not into it, there's no way it's going to happen. With kids, it's really the parents have to be full on to try it. You may need to try 3 or 4 masks, and that's pretty typical. And it may be 3 months. It could even be 6 months before you get a child to wear this. Occasionally, I think if a child will wear hearing aids or they have glasses, I'm like, oh yeah, this is going to work. And I can tell you I've been wrong more times than I'm not, because with glasses, you get sort of an immediate change in your view. And with hearing aids, it's typically kids feel better, not always, but for the most part, they hear better. With Cpap, it can be weeks before they realize, oh, I do sleep better when I'm wearing my Cpap. Supplemental oxygen can be used, but it's really only recommended in infants. We don't have that many children that need a tracheostomy for sleep apnea, but occasionally we do. And then I would say anytime you get treated for obstructive sleep apnea, a repeat sleep study is very important because you want to make sure it has all resolved. So lastly, I just want to touch on some other considerations in regard to sleep, particularly with children with charge. So the role of pain management, I think that was brought up, that children managing pain is an issue, particularly at night. And I will tell you that people who have ongoing pain, children particularly, they do not sleep well. The sleep architecture is disrupted. They don't get into deep sleep. We have many patients that have sort of chronic pain syndromes, and we've really tried to work on biofeedback and working with your medical professional for medication management, as well as physical therapy and occupational therapy. As Dr. Wiley said, the importance of a bedtime routine cannot be stressed enough, and a daytime routine. We don't recommend running the kids out. So I think there's a little bit of a myth out there that if you get your kids so tired, they're going to sleep at night. And really, most of us feel like sleep begets sleep, and it's just really a combination of what you're doing during the day and what you're doing at night and keeping that routine stable. Also night terrors and sometimes nightmares, but especially parasomnia, sleepwalking, sleep talking, those tend to get worse if the child is exhausted or if their routine is disrupted. So we do phase shifting with melatonin and with light therapy. So Dr. Wiley talked about the dinner time dose of melatonin, how that can kind of get the melatonin and boost your melatonin a little bit, and then you can give a bedtime dose. For some children that wake up in the middle of the night, I'll also give a half dose in the middle of the night if they still have 4 hours of sleep time left. I usually recommend you try that on a vacation or a long weekend because you don't want your child to be super groggy in the morning if they sort of over-responded to it. But that can be very effective. And behavioral and medical management of insomnia, what I just talked about, can really be crucial if you use a little bit of melatonin. We have other medications we use, but that's probably the easiest to try to manipulate if you're trying to do some strategies at home. And the last thing I want to stress is, I see a lot of families that have kids with sleep problems, and it really can wear you out as a caregiver. It's really hard if your child's not sleeping and you're not sleeping. And I would just urge you to get help. I think behavioral pediatricians have great strategies. They know to talk to us as a sleep provider. And then we have a sleep psychologist at Children's, and there are many around the country that specifically work on cognitive behavioral therapy and strategies within the home to help with sleep. So I think we have enough time for questions.
I want to make sure people know you're not, we don't have to stop with melatonin.
Oh yeah, so I'm not, just as a disclosure, I don't always recommend melatonin. I think light therapy can be very effective. But for some kids, you're just trying to kind of break a bad sleep habit. It can be helpful to get them back on track. But I recommend you work with your provider. Some families want to do it at home on their own. As long as we've kind of talked it through, I'll let them do that. For the most part, I think you really should have a physician helping you with that.